Hello, this is the emergency tutorial 5 on acute respiratory distress syndrome presented by the SchrDbb with reference Harrison Internal Medicine by Dennis Caspar et. So, acute respiratory distress syndrome, what's the definition? Acute respiratory distress syndrome develops rapidly and includes severe dyspnea and diffuse pulmonary infiltrate. So this patient, you are going to have severe dyspnea. He has diffuse infiltrate or into both lung field. It means that what you have a reticular lesions in both lung fields. Pulmonary infiltrate, we have an hypoxemia. So those are the three main criteria inside. You have dyspnea, diffuse pulmonary infiltrate, hypoxemia. It typically causes respiratory failure. So after acute respiratory distress syndrome, now you have respiratory failure that I'm going to see in the next session. So key diagnostic criteria acute respiratory distress syndrome include diffuse bilateral pulmonary infiltrate on X-ray. So if you see reticular lesions diffuse on both parts of the X-ray, you can think of acute respiratory distress syndrome. That's the first one. Second, we have partial pressure of oxygen. That's arterial blood pressure of oxygen in millimeters of mercury divided by the fraction inspired oxygen. The fraction inspired oxygen should be less than 200 millimeters of mercury. Means that the arterial pressure, the one that is coming in the artery, and the one that is being inspired. So the one coming into the artery and the one that is going to be inspired, the fraction that is inspired, usually, we know that one, you know that the normal fraction of oxygen in air is 28%. Is it clear? So you have 28% underneath. Is it clear? Now we also know that the normal arterial blood pressure is how many? The normal arterial blood pressure is 80. Is it okay? So, or is greater than 80. So if you do 80 divided by 0.8, it should not be less than 200 millimeters of mercury. So if it is less than 200 millimeters of mercury, then it implies that if it's less than 200 millimeters of mercury, it implies that there is very low partial pressure of oxygen. Is it clear? So you need to also, this formula is very empirical. It's not just the partial pressure of oxygen, but it's partial pressure of oxygen divided by the fractional inspired oxygen, because the more you increase oxygen inside your ventilation machine, the more oxygen is going to increase inside the blood vessel. Just imagine that you reduce oxygen inside the ventilation machine, oxygen also is going to reduce inside the blood vessel. So in order to make sure that this account should not be taking place when you are trying to diagnose acute respiratory distress syndrome, that's why you need to do the division. That's partial pressure of oxygen divided by the fraction of inspired oxygen, such that it should be less than 200 meters of mercury before you conclude that it is acute respiratory distress syndrome. The third one is absence of elevated left atrial pressure. If you have absence of the elevated left atrial pressure, because if the left atrial pressure is elevated, it will make you more think of a cardiogenic pulmonary edema rather than a respiratory distress syndrome. Is it clear? So the first thing that you're thinking, you have to have bilateral or diffuse pulmonary infiltrates. That's the first thing. Bilateral diffuse pulmonary infiltrates on X-ray. That's the one. Number two is a partial pressure of oxygen all over fractional inspired oxygen should be less than 200 millimeters of mercury. Number three, the left atrial pressure should be low. It should not be. That means that what the capillary wedge pressure should be less than 18, and what we initially saw was 20. So we can just use the value 20. Is it clear? So acute lung injury is related but milder syndrome. So you have acute respiratory distress syndrome, you're finished with it. Now we go now to acute lung injury. So acute lung injury is the milder form of acute respiratory distress syndrome with less profound hypoxemia. In this case, the hypoxemia is going to be partial pressure of oxygen over fractional inspired oxygen is going to be less than 300 millimeters of mercury. That can develop into acute respiratory distress syndrome, and then acute respiratory distress syndrome can develop into a respiratory failure. Although many medical and surgical conditions can cause acute respiratory distress syndrome, most causes, that's greater than 80% of acute respiratory distress syndrome, is going to be due to sepsis, is going to be due to bacterial pneumonia, it can be due to trauma, it can be due to multiple blood transfusions. So those are the major causes of acute respiratory distress syndrome. So it can make you think acute respiratory distress syndrome can be a pulmonary edema, a form of pulmonary edema, because you have infiltrations at the lungs. But if you want to say that acute respiratory distress, because pulmonary edema is more of a clinical syndrome than a diagnosis, is it clear? So acute respiratory distress syndrome also is a clinical syndrome than a diagnosis, but it's a better form of syndrome. Is it clear? So the cause of acute respiratory distress syndrome can be sepsis, it can be bacterial pneumonia, it can be trauma, it can be multiple blood transfusion, it can be gastric acid aspiration, and it can be drug overdose. Now, individuals with more than one predisposing factor have a greater risk of developing acute respiratory distress syndrome. Other risk factors include older age, chronic alcohol consumption, all the likes. So what are the clinical causes? So the clinical cause of acute respiratory distress syndrome is going to be exactly like the cause of inflammation. When you have a wound, this clinical cause of acute respiratory distress syndrome is just like the cause of wound healing. Is it clear? So the first thing is you have injury first to the lungs. Are you getting? So when you have injury, the injury to the lungs can be due to pneumonia, it can be due to sepsis, it can be due to trauma. You first have the injury to the lungs. When you have injury to the lungs, you first have the exudative phase. Are you getting? So the exudative phase now is a phase where you have inflammatory products which are going to be released. So inflammation is going to be released. Now we have the second one now is a proliferative phase. Proliferative phase now when the granulation tissue are going to come into place, and then you have the fibrotic phase now when you have scar production. So exudative phase characterized by alveolar edema. So you see that acute pulmonary edema is part of acute respiratory distress syndrome. So when you are on the exudative phase of acute respiratory distress syndrome, it is actually acute pulmonary edema. So it's characterized by alveolar edema and neutrophil inflammation with subsequent development of hyaline membrane. So you have hyaline membrane here with diffuse alveolar damage. The alveolar edema, which is most prominent in the dependent portion of the lungs, causes atelectasis and reduced lung compliance. If you have alveolar edema such that there is no surfactant that is going to be produced because the cells here are being destroyed. So you have the type 2 pneumocytes are going to be destroyed if you have a lung injury. When they are going to be destroyed, you don't have any surfactant production, you have a hyaline membrane production. So that's going to now result to a lung collapse. So and reduce lung compliance. That is going to make now hypoxemia, tachypnea, progressive dyspnea develop and increase pulmonary dead space. Now, respiratory failure frequently develop during the phase of exudative phase. Chest X-ray revealed bilateral diffuse alveolar interstitial opacities. You can see interstitial opacity, you can see reticular lesions. The differential diagnosis is broad, but common alternative etiologies are cardiogenic pulmonary edema, pneumonia, and alveolar hemorrhage. Unlike cardiogenic pulmonary edema, the chest acute respiratory distress syndrome rarely show cardiomegaly and pleural effusion or pulmonary vascular redistribution like in cases of the heart. Now the case now of the second one is proliferative phase. The phase typically lasts approximately 7 to 21 days. In cases of the distributive phase, the inflammation phase is going to last for 6 days. Then proliferative phase, just like wound healing, is going to be from 6 days to 6 weeks, or from 7 days to 21 days. So although most patients recover, some will develop a progressive lung injury and evidence of pulmonary fibrosis. Sometimes you need to know that the pneumocytes can proliferate and go to the part that has been injured, so making the lungs to recover. But some people, the lung may not recover, and you may have development of fibrosis, pulmonary fibrosis. Even among patients who show rapid improvement allowing removal of mechanical ventilator, develop dyspnea often persists during this phase. So if you have a dyspnea that persists during this phase, you can think of fibrosis that occur in the proliferative phase. Then the next one is the fibrotic phase. In fibrotic phase, although the majority of patients recover within 3 to 4 weeks of initial pulmonary injury, some experience progressive fibrosis necessary of prolonged ventilation. So your fibrosis is going to necessitate prolonged ventilation. So increased risk of pneumothorax, reducing the compliance of the heart. So the treatment now, we have initial management of acute respiratory distress syndrome. So if you have you have to initiate volume and pressure limited ventilation. You initiate volume and pressure limited ventilation. You have to make sure that you have to give oxygen, but the goal should be that it should be that the tidal volume should be less than 6 mL per kilogram per body weight. At the plateau pressure, when you are giving oxygen, don't give the oxygen more than 30 centimeters of water, and the respiratory rate should be less than 35 breaths per minute. Now you oxygenate with oxygen of less than 0.6%, so 60%, so less than 0.6 fractionated oxygen. You make sure that the positive end expiratory pressure, you have a positive end expiratory pressure should be less than 10 centimeters of water. The plateau pressure, that is the pressure that is going to be on the plateau, that is going to flow all through, is going to be 30 centimeters of water. And then the pressure that is going to be at the end of expiration is going to be less than 10 centimeters of water. Now your saturation should be between 80 to 95%. Minimize acidosis by make sure that pH should be greater than 7.3. Respiratory rate, the 35 breaths per minute, and diuresis. So in acute respiratory distress syndrome, a mechanical ventilators are actually very needed. So patients of acute respiratory distress syndrome typically require mechanical ventilation support due to the hypoxemia and increased work of breathing. It has been clearly shown that low tidal volume, that is less than 6 millimeters of water per kilogram body, provide reduced mortality compared to a high tidal volume. So just need 6 millimeters mils per kilogram per body weight to make sure the patient lives very well. Acute respiratory distress syndrome, alveolar collapse can occur due to alveolar infiltration, fluid accumulation, and loss of surfactant. It is okay. So what is the outcome? Mortality from acute respiratory distress syndrome is going to decline with improved general critical care. Maltreatment and with the introduction of tidal volume ventilation, current mortality with acute respiratory distress syndrome is 26 to 44%, with most due to sepsis and pulmonary organ failure. So now the next thing you're going to visualize now is respiratory failure. So immediate complication of acute respiratory distress syndrome is going to result in respiratory failure. So what is respiratory failure? Respiratory failure is defined as inadequate gas exchange due to malfunction of one or more component of respiratory system. So there are two main types of respiratory failure. You have type 1, type 2. So the first one, which is type 1, you have hypoxemia, and we have, so the first one you just have hypoxemia, and the second one you have hypoxemia and you have hypercarbia. Are you getting? So hypoxemic respiratory failure defined as oxygen saturation of less than 90% while the patient is receiving inspired oxygen fraction. So when you have an inspired oxygen fraction and then you have your oxygen saturation of less than 90%, it's going to be defined as respiratory failure. Acute hypoxemic respiratory failure can result from one. So if you have just a hypoxemia, that's a type 1, it can result from pneumonia, it can result from any ventilation perfusion disorder like pneumonia, like pulmonary edema, like alveolar hemorrhage. So hypoxemia results from a ventilation perfusion perfusion mismatch and intrapulmonary shunting. Is it clear? Now, in case now where you have hypoxemia, hypercarbia, respiratory failure. So this one now, hypoxemia, hypercarbia, respiratory failure, is going to be characterized by alveolar hypoventilation and respiratory acidosis. So we have alveolar hypoventilation, we have respiratory acidosis. To have respiratory acidosis. So in this case, we have alveolar and respiratory acidosis are the main one which are involved with hypercarbic respiratory failure, respiratory acidosis, and alveolar hypoventilation. So in this case, hypercarbic respiratory failure actually decreased ventilation, so physiologic. So condition is going to be associated with neuromuscular disease like myasthenia gravis. You have in case of the diminished respiratory drive, like in case of drug overdose. You have brainstem injury. You have in case of respiratory damage associated with respiratory muscle fatigue, like excess of chronic asthma, chronic obstructive pulmonary disease. You have acute hypercarbic respiratory failure, has a partial pressure of carbon dioxide. The partial pressure of carbon dioxide will be greater than 50 millimeters of mercury, with an acute on chronic respiratory failure, as often of chronic exacerbation of chronic obstructive pulmonary disease. Now, what are the modes of mechanical ventilations? So we have different mechanical ventilation quite here. Is it clear? So the first mechanical ventilation, these are all the mechanical ventilation which are not going to be given, and the patient can visualize in Harrison Handbook of Internal Medicine. The next one is going to be mechanical ventilation of ventilated patients. So I'm not going to do it. You're going to visualize it by yourself. So the next thing you're going to visualize in the chapter is going to be confusion, stupor, and coma. Thank you for your kind attention.